morning. Alembic have always been supporting knowledge-based initiative to build the skill and confidence of our medical practitioners with a global to ultimate with a goal to ultimately help to improve patients' care. Alembic Masterclass for the Eternity Fraternity being one of the flagship initiatives in the end of year. The history of Alembic Masterclass goes back to the year 2013 when it was started with small but with definite steps. Over the year, Masterclass has grown from year today is one of the most sought after academic initiatives in India for the ENT fraternity. And that has helped only because of the love and support that has been received by each one of y'all. Alembic Masterclass is back as Masterclass Prime this year. It brings you an opportunity to witness live surgery cases performed by our eminent faculty members, which you can replicate in your own OTs. Without taking much time of yours, now let me call Mr. Rajit Kumar, a Vice President, Sales and Marketing at Alembic Pharmaceutical Limited, to share his message with all of us. Sir, over to you. Hello. Rajit sir, are you there? Am I audible to everyone?
Yes, yes.
Okay.
Yes, ma'am.
Yeah. Hello. Check.
Rajit sir, are you there?
Ma'am.
Hello, good morning. This is Dr. Vijendra from Bangalore.
Good morning,
Hello.
sir.
Hello.
Hello. Yes,
Good
sir.
morning. This is Dr. Vijendra from Bangalore.
Good morning, sir.
Good morning. I think Rajit is still sleeping. It's like
Hello.
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 Am I audible?
Yes, sir, you're audible.
Yeah, good morning, Vijendra sir. Hello.
Hello, can you hear me?
Hello. Good morning.
Yes, sir, we can hear you.
Good morning,
Very
Vijendra
good,
sir.
very good.
Dr.
Excellent.
Deepak from Bangalore.
Yeah.
Hello?
Now I think you can hear me. My screen is visible to all of you?
Not
Yeah, I
yet,
think
sir.
section, please. Section done.
My screen is visible to all of you?
Sir, you're audible.
Yeah, narrow section.
Yeah. You can see me?
Yes, sir, we can see you.
Oh, wonderful. You can
Give me
see
the
my
pack.
screen?
Squeeze it well and give her.
Yeah, you put it in the main screen.
Ribbon goes.
You have to change it to the main screen. Hello?
Sir, your audio level is very low. Please increase your audio level.
Yeah, is it visible now?
Yes, sir,
screen
it's
is
visible. Yes,
My
yes.
screen is visible? Yeah, wonderful. Good. So let me start. Good morning to all distinguished faculties, moderators, participants,
When I
all
I have a
ENT
small
surgeons
Caesar
connected,
to cut the hairs, nasal hairs.
42 web centers
Allah, first
all over
Rajit.
India, and my colleagues who are the pillars of Masterclass success. Let me take all of you 10 minutes of your time, the journey of Alembic, touching lives over 100 years. Alembic is young, 115 years, company of touching lives since 1907.
Section got blocked. Put a stillet. Have you taken a stillet?
Alembic, 115 years of making science work for people through unmatched regulatory track record, cutting edge science to help people live their best life.
Give me the sponge.
Alembic, a laser sharp focus and world-class process, enable us to remain ahead of the compliance curve. In cutting edge science to help people live their best life, we take a closer look at things, ask questions, and bring life-changing healthcare solutions. Our mission is to bring you access, information, and innovations in healthcare. Just to take you our business, we are present in brand formulations, API, and international generics. In brand formulations, we are present in India and emerging markets like Southeast Asia, Africa, and CIS countries.
Hold this.
API, showcasing our ability to develop new product in line with larger global formulators. In international generics, significant presence in the US, Europe, and other markets. Taking you our global footprints, we are present more than 40 countries.
Thank you.
Our representation offices are in 7 countries. Our third-party distribution setups are in 23 countries and more than 40 brands available across the globe. We have our certifications and accreditations in FDA, MHRA, FDCA, Australian Government Department of Health, Medicine Control Council, South Africa. Alembic has been awarded and recognized by Thomson Reuters and Forbes for awarded for innovative marketing practices, and we in Forbes amongst top 50 companies in India across sectors. Message from our chairman and managing director, Mr. Chirayu Amin: our transformational efforts have only started yielding results. The best is yet to come. Doctors, I just want to take you through our India business. We have 19 strategic business units across with different therapies, different divisions which we are working. More than 12,000 employees are working. We are known in leaders in macrolides, the brands which you know very well, like Azithral, Roxit, Altrocin, and Clof. We have our significant presence in more than 10 key therapeutic areas. You must be knowing, many of my colleagues must be meeting you, who are actually associated with many therapies like anti-infectives. We are there, gastroenterology, antihistamines, gynecology, cold and cough, ortho and rheumatology, cardiodiabetic, dermatology, and critical care. Taking forward, I just want to show you some glimpse of our flagship brands. Yes, Azithral, azithromycin. We have Roxit, Clof, Vicoril, Leveta, Zeet, and Brozid, Altrocin. These are some of our flagship brands for Alembic. Moving towards, we always believe science is important. Bring in science for better patient care. For reaching to doctors, upgrading their knowledge. We have many activities, scientific symposiums, scientific forums, sharing science through activities. Some of the activities which I've shown you here are associated with all the therapies like cardiodiabetes. We are present for general practitioners, general physicians, and pediatricians, of course, in ENT segment, uro, gastro, and all these activities are well connected. We keep doing activities to upgrade the knowledge of doctors, and we connect doctors frequently through these activities and scientific forums. Moving forward, yes, today's program is basically for ENT fraternity. We always believe this is one of the important specialty for us, and we always want to make a very special bonding with this specialty through our Alembic Masterclass. I just want to take you for 10 years back. This idea has come and we have floated this, and today we are big of doing Masterclass, and this is actually taking to a lot of ENT surgeons and up to for upgrading the knowledge. This bond was strengthened with the pioneering initiative. 10 years back at Bangalore, we started back in ages of Dr. H. Vijayendra and Dr. Deepak Haldipur. It's not good from my part if I don't highlight a special name, a name, which has really actually helped us to guide to reach to Dr. H. Vijendra is none other than Dr. R.S. Mudul. R.S. Mudul is our Vice Chancellor from Bijapur BLDE Hospital. So thank you, sir, for making us and taking us to the doctors like Dr. H. Vijendra, Dr. Deepak Haldipur to start 10 years back. And today we have entered, and this is the 10th year of our program. I'm very happy to share with you, we are raising the bar every time through our ENT Masterclass. And today we are into the 10th year. Thank you very much for all the support which you have given for the last 10 years to upgrade, to get the best of best cases, and to actually improvise our program every year. And doctors today are looking, all of us looking that Masterclass is one of the prime. Today, why Masterclass and why ENT? Yes, we are associated with Masterclass. It's a major activity with ENTs, but we are also present to upgrade the knowledge of doctors in ENT fraternity through different activities like Connect with Legends. Basically, the concepts are all different concepts what we have brought. A Saturday evening talk from the legends on the particular area of expertise. Grand rounds, this is basically for PG students before they enter into Vivas. Genext, this is for the PG students. We do a lot of quiz and inter-college competitions. Fellowship programs, we take doctors who are interested for different therapy, so different areas of ENT, and we take them, work along with other doctors, and we actually give the fellowship for the doctors. That's how the entire program is associated for ENT fraternity. Today, why Masterclass is prime now, a class apart. Masterclass presenting to you never seen before scale. One area where I just want to tell you is that today we have upgraded ourselves, and we want to see that Masterclass, how in next level we can enter. Today, Masterclass has become prime, a class apart, because a class apart because of faculty panel, a class apart because of selection of cases what we have today. That's one of the area where we have moved up into Masterclass prime, a class apart. Because of this hybrid model, today doctors are not able to reach the main center. So we have made almost around 42 web centers across India. In Pan-India, 42 centers are actually watching live this program. Physically, doctors are available across the 42 centers. And I'm very happy to share with all of you that yesterday night, we have 2,200 doctors registered for the program. Those doctors are physically available today at more than 42 centers. Now we are made into Masterclass Prime into 3 modules. Every 3 months we will be touching upon ENT surgeons. How which is made, August 14th we have.
Camera feed program.
Hello, Rajit sir. Hello. So we can't hear you. Hello, Rajit sir. So we can't hear you.
All the centers, can you just confirm? Yeah. Now, Didi, can you hear me?
Sir, we can hear you.
Right. So,
So the slides are not visible.
acha, fine. Slides are not visible. Now?
Yes, sir, we can see.
Wonderful. So you have seen the last slide, this slide?
Yes, sir.
Wonderful. Okay, fine. You heard about this slide?
Sir, we could only hear the partial, the half part of it. So it would be great if you repeat it.
Wonderful, right. Once again, I just want to highlight here, while we are into Masterclass Prime, a class apart, today with this hybrid model, we have connected with 42 centers physically with all the ENT surgeons. 2,200 doctors yesterday registered for this program, who will be physically available in across span India of all these 42 centers. We made this module into 3 set, August, November, December, one-day program with 4 surgeries. That's how we planned the entire program. And in this time, we have added 3 sessions on practical essentials. So every time we will be adding 1 session on the practical essentials by different eminent doctors, and 12 surgeries, which is lined up for this 3 programs, 3 modules, what we are showing here. This is some glimpse of our faculty panel. Just want to highlight Dr. H. Vijayendra, our mentor, Deepak Haldipur, our course coordinator, and we have Dr. Janaki Ram, Dr. Virendra Gaisas, Dr. Mubarak, Dr. Sanjeev Kumar, Dr. Sultan Pradhan, Dr. Sadish Jain, Dr. Vikas Agarwal, Dr. Vishwas, and Dr. Simap Sheikh, Dr. Anand. These are all the faculties which is associated for all 3 programs, like this program plus November and February. A class apart selection of cases, we are known, and I must thank Dr. H. Vijayendra and Dr. Deepak Haldipur for really giving us the best of best cases every time and upgrading the masterclass in this level. Really the work what Dr. H. Vijayendra, Dr. Deepak Haldipur is supporting us, I think I really have to mention here, thank you sir for all the support which you have made to make the masterclass in this level. And today our faculties, it's the program starting with Dr. Deepak Haldipur, Dr. H. Vijayendra, Dr. Simap Sheikh will be talking, and then Dr. Janaki Ram, Dr. Virendra Gaisas, and again Dr. Janaki Ram. This is how the entire program which is scheduled, and I'm sure today's program is going to enrich yourself to the best is yet to come. Alembic touching lives over 100 years. Again, I just want to we are young 115-year company, which is always giving the best of best academic feast to you. And today I'm sure this feast is going to help you all to upgrade your own practices and to part this benefits to more number of your patients who are going to come. Thank you. Let me hand over back to Ms. Diti. Diti, I have done from my part. Over to you.
Thank you so much, sir, for sharing this wonderful information with us. Now, I would request Dr. Dinesh Patel.
Hello, Diti.
Hello. Hello. Am I audible?
Hello.
Hello. Am I audible, sir? Hello. Am I audible?
Yes, yes, you're audible.
Okay. Thank
Not
you so
hearing.
much for the confirmation.
Yeah.
I would repeat. Thank you so much, sir, for sharing this wonderful information with us. Now, I would request Dr. Dinesh Patel from our medical team to introduce our esteemed speaker for the day. So, over to you.
Good morning. Good morning, dear doctor. I'm Dr. Dinesh Patil. Welcome you all on behalf of Alembic Pharmaceutical for this today's Masterclass Prime ENT Live Surgery Module 1. Masterclass Prime Live ENT Surgery Module 1 is wherein you will get an experience of live surgeries conducted by an expert. Due to popular demand and feedback received across the delegates across India, the Alembic Masterclass Prime now be held for 3 days program, and for this I warmly welcome our honorable faculties and delegate across the India who joining us today for this scientific activity. Today we will have a session, debates, discussion on various ENT and skull-based surgeries. Before we kickstart these surgeries, I would like to express my gratitude towards you all who sincerely contributed to this event in order to make it success. I consider it great honor to welcome our mentor, Dr. H. Vijayendra sir, on the stage for opening and welcome remarks. Over to you, sir. Dr. Vijendra sir.
Very good morning, all my dear friends all over the globe and all the 42 web centers. I sincerely thank Alembic people for giving me this opportunity to be a mentor for this wonderful, wonderful program. I can say this is a very popular live surgical program in India. So I sincerely thank Rajit and his team for this wonderful arrangements. This time, they have labeled it as Masterclass Prime. I asked Rajit, what is Prime? Prime means they have gone to a higher level. So all this time, nearly about 600 to 800 doctors used to watch physically. Now they have gone beyond that. It is really amazing that they have arranged in 42 centers all over India, even at a small district places. So the main idea is this live surgery or teaching program of ENT should reach each and every ENT surgeon from nook and corners. So yesterday Rajit was telling, even if there are 30, 40 people from a district place and they request that we cannot travel 100 kilometers to go back, they have made arrangements. This is wonderful, wonderful arrangements they have made. And this physically more than 2,200 doctors watching at the same time is amazing. This is probably the first time so many people are watching a live surgery all over the India. So I am really grateful and thankful to Alembic people. So as Rajit was telling, it is a 115 years young Alembic company doing a wonderful job. This Alembic company is a household name. Everyone knows about azethral. So even a layman knows about azethral. So that is the name and fame this Alembic people have made throughout. To start with this, how this master class started. So about 10 years back in 2013, myself and Mudol and one of the representatives from the Alembic, we were having a meeting, and then I suggested what is the best way to attract people or the teach ENT is only live surgery. So you go to any conference, so people will be not interested to listen to lectures for a long time. So whereas when you do a live surgery, all the people will be glued to their chairs. So with this motto, I suggested, and this master class, the birthplace of master class is the place where I am sitting here. The first master class live surgical demonstration started from my own OT where I am sitting here. And in 1913, we did it. In 2013, we did this. Unfortunately, at that time, it was clashing with my beloved teacher, Dr. Mahadeva's 80th birthday. We clubbed these two things. And when I operated in my hospital in the same place where I am sitting, it was telecasted in Taj West End Hotel. And at that time, we had a foreign faculty. My dear friend Vincent had come from France, and we operated 5 cases. And that's how the birthplace of this master class has started. And every year it started growing, and people are thriving and they're waiting for this master class. Wherever you go, they'll ask, "Sir, when is the master class?" So all these days we used to do a live surgery for 2 days because of some technical problems. As Rajit said, it has been divided into 3 modules. That is also a very good idea. And this first module today we are going to enjoy. I welcome everyone. And today the surgeries lined up are very nice surgeries. The opening batsman is none other than the legend Deepak Haldipur. He will be operating from his hospital, that is Trustwell Hospital. He is doing extensive acute polyposis. After that, I will be doing my case. And then somewhere I will be going to give about OSA. And next, the hero of the day, that is none other than Janaki Ram. he has selected a beautiful cases. One is a pituitary tumor completely engulfing the internal carotid artery. It will be really a feast to watch, and nobody should miss this. So that is the first case he's doing. After that, our Indian Gubesh, I call Indian Gubesh, is none other than our Virendra Gases. He is the Indian Gubesh. He has trained under Gubesh and he is do a wonderful tip plasty. That is also, nobody should miss that. And at the end, again, the hero is going to do one more case of post-operative pituitary case of with a very massive CSF leak. And this is a beautiful case. So this will be a feast for all of you. So don't leave your chairs. Enjoy the day. And once again, I thank Alembic for this wonderful opportunity. Thank you very much. Wish all of you have a very good day. Thank you.
Thank you, sir. Thanks a lot for your opening remarks. With your due permission, we're going to start today's first surgery. Today, we have our first surgeon expert, Dr. Deepak Haldipur. He is the course chairperson of the Masterclass Prime and currently is director of Trustful Hospital, Bangalore. Sir is an internationally renowned ENT surgeon who brings immense experience spanning over 3 decades in the field of otorhinolaryngology and head neck surgery. He is one of the foremost ENT surgeon in India who has mastered excellence in skull-based surgeries, both endoscopic, anterior and lateral skull base. He demonstrated his immense knowledge as a mentor surgeon for the cochlear implant program in various institutions and hospitals. He has an extensive experience with cochlear implant, endoscopic sinus surgeries, microsurgeries of the ear, laser stapedectomy, thyroid surgeries, and other head neck surgeries. He evinces a special interest in endoscopic skull-based surgeries, repair of CSF leaks, and pituitary surgeries. Sir, over to you at Trustful Hospital.
Hello,
Yes, sir.
can you hear me?
Yes, sir.
Yeah, who are the moderators?
Good morning, sir. I am Dr. Durga Prasad from Hyderabad, Government
Hello.
Military Hospital. Yeah,
Hello,
Osmania.
sir.
Yeah.
Hello, sir. Hello, and anybody else? Dr. Durga Prasad,
Yes, sir.
about 5 or 6 years back, I think Koti Hospital, Dr. Venkatram Reddy and Sridhar Reddy had called me, where
Yeah.
I demonstrated endoscopic stapedotomy and
Yes,
a few other cases. You
Yeah,
have
yeah,
a huge turnover in your hospital.
yes, sir. Yes.
Now, are you getting the endoscopic picture?
Yes. No. We are getting the CT scan picture, sir, not the endoscopic
Yeah,
picture. Now we
yeah.
are getting, sir.
Yeah, now you're getting the endoscopic picture.
Yeah,
It's a case of bilateral ethmoidal polyposis.
sir.
Age of the patient is to? It's a 47-year-old person.
Okay, sir.
Actually, I am the stand-in batsman because Dr. Vishwas Vijaydev
No.
was supposed to do a facial plastic case today morning.
Yes, sir.
But he was unwell with dengue fever. And
Yeah.
now we are having an epidemic of dengue going on. So he is not there. So suddenly we had to post this case. I was supposed to otherwise demonstrate in the Alembic Masterclass number 2. That was in
Okay.
November, the second module.
No.
So accidentally, I happened to become the faculty today. Okay.
No
At the
problem.
outset,
Yeah.
I would like to thank the Alembic people, Dr. Mudhol, Dr. Vijayendra, and if I remember right, even Dr. Dhanraj was initially associated when Michael Tuxedo had come and we had a program in the hotel in Gandhinagar. So Alembic Masterclass over a period of time has acquired very good popularity, and in the bargain, the fringe players or medium surgeons like me we have also got an opportunity to make some name. And it's all because of you, delegates and moderators. Sunday morning, Durga Prasad, you are here at this time to moderate. I am ever so grateful to you.
Thank you, sir. Thank
Yeah.
you.
I think first I will make our anesthetist, Dr. N.S. Chandrasekhar, talk. Unfortunately, we have only one mic. So I will transfer my caller mic to him first. He will do the initial talking for 5 minutes. And then we will go ahead. Okay.
Okay, sir.
Good morning, Deepak. This is Ilambardi from Chennai.
Morning, sir. Morning.
Morning.
Sir, Matak.
Hello. Hello. Is it audible?
Yes, sir.
Huh? Okay. You want to focus? Yeah, okay. Good morning, everybody. I am Dr. Chandrasekhar, anesthetist and head of the department of Trustful Hospital. We have a small the anesthetic team. My colleagues, Dr. Josna and Dr. Jaydev are there. Today, we are having an interesting case with Dr. Deepak Haldipur. This is quite a challenging case. I just want to apprise an anesthetic point of view. He is quite an obese patient of 118 kgs, diabetic, hypertension, and asthmatic, and has a sleep apnea syndrome also. So this is quite a challenging as an intubation and as well as for the maintenance of anesthesia. Now, as you know, all head and neck surgeons wish to have a bloodless field, but it's a big challenge for anesthetists to maintain that. So regularly we induce the patient with anesthetic drugs, which I don't want to go in detail because majority of anesthetists use the same drug. But I overemphasize on infusion of dexmetadine. Nowadays, dexmetadine plays a major role in your head and neck surgery because it reduces the blood heart rate without affecting much of the blood pressure. This is a unique drug for for our management of head and neck surgery. We require a bloodless field. So, can you focus on our monitor? Possible? Okay. Turn this way. So you can see how we are, though he is hypertensive diabetic, I have maintained the blood pressure around 100, 110, and the pulse rate of around 65 to 70. Now, how to go about these cases, in controlling the sympathetic tone? One, we have to keep the head end at least 10 to 20 degrees. And the most important nowadays, what every anesthetist is concerned is about the blood pressure. How long we can bring down the pressure? It's most challenging. Usually, we have to concentrate on what we call mean arterial pressure. That is around 64, 65. This is the safe zone for patient safety regarding the cardiac issues. So our maintenance of blood pressure is not only the systolic or diastolic pressure, but it's challenging on the mean arterial pressure. So don't bring down the mean arterial pressure less than 55. 55 to 65 or 50 to 65 are the best way of keeping the blood pressure and perfusion to the heart and target organs. Now, recently we are having the post-operative outcome of the hypotension patients. That is called, we call it as MIMS, myocardial ischemia due to non-myocardial surgery. Now, this is a very big issue in anesthesia and perioperative and post-operative period. We do hypotensive anesthesia and post-operatively patient will develop myocardial ischemia. So this we have to very much aware of it. So there are many methods, many ways of preventing this. I don't want to go in deep, but mean arterial pressure is very important, and we have to maintain that. However, you wanted to bring down the pressure. And secondly is the pulse rate. So majority of the drugs which we use, they always reduce the pulse rate around 65 to 70, 60 to 65. And another safety concern in this patient are perfusion of the target organ. If you bring down the pressure, definitely the urine output will come down. Perfusion of the brain will come down. So we have to see that the mean arterial pressure is well maintained to perfuse all the structure. And another challenging here is, I know majority of our head and neck surgeons deliberately use the vasopressors, adrenaline during during infiltration or installation and all. I had a long debate with many of our head and neck surgeons. As you know, many of the anesthetists are not happy to associate or happy to give that kind of concentration of the surgeons they use for each patient. But one thing, as a physiological, we have to understand the adrenaline concentration of 1 in 80,000 to 1 in 200,000 are ideal for the capillary. See, you are targeting the capillary level. See, all adrenaline or vasopressors has wonderful effect, what you call as, one is ceiling dose effect, second is dose related response. If you increase the dose, the response will also goes up, but that will not work for all the vessels. See, if you look at the generation of arteries, from big vessel, it comes to medium size, large size, medium size, and up to the capillaries. And you are targeting at capillary level, and you don't need to use high dose of vasoconstrictors because it will not work. It will only stays whatever the capillary the dosage between 118,000 or 200,000. The more the drug you use, majority headaches still they argue that they get better field, but scientifically it does not work like that. So, but anyhow, it is a myth, and many surgeons follow. So we also go along with them. And secondly, we are already worried about any head and neck surgeon when they do on the local, what we develop toxicity. So and allergic anaphylaxis reaction. If the patient gives a history of anaphylaxis reaction, for example, for xylocaine, that is called amide group of local anesthetic, you can always change over to ester group of local anesthetic. So they are very limited, but now ester groups of drugs are also coming. But you can always change out either bupropion or other drug. So no need to hesitate. And your adrenal also support in case there is any change in the perfusion. Okay, I am happy to answer in the course of the surgery if you have any questions. Thank you all.
This is Dr. Durga Prasad. Am I audible, sir? Dr. Chandra, sir?
Yes, sir.
Yeah. A few relevant questions, sir.
Yeah.
Like, for example, even if you give hypotensive anesthesia and the patient recovers, the blood pressure is going to return to normal.
Yeah.
And post-operatively, is there going to be troublesome bleeding? Is question of some of the junior colleagues, they keep asking me. Suppose we have induced hypotensive anesthesia during surgery, what about the post-operative period when the blood pressure returns to normal?
Yeah, it's a very good question. See, when we start the case, we always use deliberately tranexamic acid to prevent the blood pressure, to prevent the oozing at the site. It helps a lot to maintain. See, we have to plan what is called as polyformic approach. It is not just giving the volatiles, dexamethasone, and tranexamic acid and other drugs. So you have to use multiple drugs to bring down the blood pressure. And once the at the end of surgery, we have to bring back the blood pressure at least to near normal level, so that if there is any ooze or anything, so before the surgeon could pack, we have to control it. So at least we have to do at least, and we have to give sufficient time before extubation to normalize the blood pressure. Okay, then after that, once we extubate, at the time of extubation, you will have a sympathetic reflex because patient coughs on the tube and we are doing suctioning, again the BP goes up. So we have to use deliberate beta blockers, particularly labetalol. So we always keep labetalol throughout the period. It is a wonderful beta blocker with alpha action, very safe. It's got 5 milligram per ml. We can give up to 5 to 20 milligram, depending upon controlling the blood pressure. It's an instantaneous act. And we have to watch this because yours is a very valid question. Many times the pack will get wet at the time of extubation. So we have to prepare, anticipate this hypertension. So give vasopressor, give the beta blockers, keep ready in this. And sometimes we also use nitroglycerin NTG, where the patients who are already unstable in maintaining the blood pressure. All these things even will know, an anesthetist will know during the surgery. He knows how the labile hypertension, how the blood pressure goes. He should actively, involve with the patient and find out whether this patient behaves normally or not. So it will give an idea to the anesthetist at the end of the how, if I extubate this patient, how he is going to, his blood pressure will fluctuate. So it's a very good question, but we have to use deliberate beta blocker or vasodilators. If you don't have any other thing, at least you can give 2 ampules of Didipili, which is a good vasodilator and safe at the end of surgery. Thank you.
Yes, sir. And suppose, of course, we would like a bloodless field anyway, and if you reduce the blood pressure, it's welcome. But the pulse rate is going to rise. So, given a contrast between preoperative atenolol, some beta blocker like atenolol or metoprolol for a week or so, because it doesn't cause precipitous fall of blood pressure, and maintain at the same pressure during the surgery versus reducing the blood pressure during surgery. Which do you prefer, sir?
See, it is instant answer of many anesthetists. Many people, they include beta blocker as a pre-medication. So they give a tablet of metoprolol or have a beta blocker at the time of induction, before induction or at the time of induction, and continue with that. So I prefer giving beta blockers to reduce the rate depending upon the biological behavior of each patient. Each patients are entirely different. So I observe at the time of induction, and if there is any more than 10 to 20% of the pulse rate variation is there, I immediately start using beta blockers. So it depends on the anesthetist whims and fancies, but we have to reduce the rate. And particularly, I wanted to overemphasize that young patients are very resistant to bring down the pulse rate. That's what I have noticed. Even despite of giving many beta blockers and other drugs, it's very different. They are not resistant. It's not easy to bring down. But we have to make other maneuvers to bring down the blood pressure as well as the pulse rate.
And as you rightly mentioned about the possibility of myocardial infarction.
Ischemia, sorry, MIMS.
Ischemia. Ischemia. Actually, we have observed frank myocardial inferior infarcts in some of the cases.
Yeah.
So, and even with adrenaline, some of our older professors used to warn, be careful because that can give rise to spasm and coronary spasm and ischemia. Is there any way during surgery with your monitoring of predicting ischemia post-operatively?
Sir, very good question. If you look at this, at the monitor, so all the monitoring is a medical turnkey in anesthesia. Without monitors, we cannot do anything, this kind of procedures at all. See, you have, whenever there is an, in the ECG, any changes are there, the STT changes are the most significant. And in monitoring anesthesia in ECG, we have to do, along with lead 2 is the common ECG, along with that we have to do V5 monitoring. So that V5 is the very sensitive ECG wave which detects the ischemia instantaneously. Of course, I have our technicians have not placed on V5, otherwise I would have shown it. There the dual channel cascade ECGs are there, where you will get 2 lines of ECG. So V5 is very significant. Whereas this lead to monitoring, what you are seeing is only for arrhythmias and pulse rate. This will not reflect ischemia. So that V5 monitoring will know that how the patient is going for any ischemia or STT changes. So we have to predict that, and immediately we should start on cardiac protective drugs like nitroglycerides, NTG, infusion, or such things we have to do. So it is important to detect and aggressively intervene at that stage.
So V5 is the crucial wave.
V5 monitoring.
On the monitor there is glare, sir. Can you avoid that? There is glare on the monitor here. If you can show V5 where exactly you have to see, that would be beneficial.
I will just show the.
Now it is good.
I will show you what is the V1. This is the V5 monitoring. What you are seeing is, this is the V5 complex.
Okay, sir.
So any change in the SCT will immediately reflect into the system, into the monitor.
Okay.
So there are excellent monitors where it itself predicts SCT changes and tell you how much, whether elevated or depression. So you can see, though this patient is hypertensive, I have maintained the pulse rate of 75. Probably I am going to reduce some more. And the mean arterial pressure is 67. Still, I have the liberty to reduce for another 5 millimeter of mean arterial pressure. But I'm not too much worried about systolic pressure. So mean arterial pressure is the key in maintaining the perfusion and predictive, one of the predictive index for myocardial ischemia in the perioperative situation.
Some patients might have prinzmetal angina that might not be very well reflected in ECG. Any warning factor with which, if we give adrenaline, the patient is likely to go into coronary spasm? Is there any preoperative method or any wave that we must specifically see to predict it?
Sir, this is, this perioperative is very difficult to predict. But preoperative workup is very important, where we do what you call as, if the patient is already having prinzmetal angina, we have to submit them for extensive cardiac workup, and particularly dobutamine stress test is one of the things which know that how the patient has ischemic changes. Dobutamine stress test. And also if the facility is there for Muga, what is that? Radioisotope study on coronary perfusion, that is also very good, which is also more accurate. So we have to do it only preoperatively. Perioperatively, only the SCT changes we can detect and do it. But prinzmetal angina and all, we already knew what the patient is having problem. So we have to thoroughly assess, and we have to give the cardiac protective anticardiac drugs.
No, when we predict this type of coronary spasm and still we are forced to give adrenaline, is there any cardioprotective drug that would prevent ischemia?
No, that is why we can start with nitroglycerin, NTG infusion we have to start. And some of the head and neck surgeons have the myths that the moment you start NTG, they will have vasodilator effect and the bleeding is more. But here the protection of the cardiac is important. So we have to check the way benefit and risk ratio, and we have to start on nitroglycerides.
Thank you very much, sir. Thank you. That was very illuminating. Very illuminating, sir.
Okay, sir. Thank you very much, sir.
Thank you, sir.
Hello. Hello.
Good morning,
Hello.
Deepak sir.
Yes, sir. Yes, sir. Yeah.
Am I audible?
Yes, sir.
Yeah, Dr. Durga Prasad.
Yes, sir. Yeah.
Dr. Ilam Bharti is also
Yeah.
there, I think.
Yes, sir. Good morning.
Sir,
Mike,
good
correct,
morning.
sir.
Seema Beer.
See, actually, Dr. N.S. Chandrasekhar and me are associated now for more than 2 decades. करेक्ट बेटा है क्या? देख पहले नहीं, इधर सर के ऊपर भी करेक्ट बेटा है क्या? गिरेगा नहीं? ओके, नहीं नहीं ठीक, तू एक बार चेक कर ले बस. हाँ, so actually he's been an amazing anesthetist, and the biggest advantage is he never almost refuses a case for general anesthesia. I think let me go to the CT scan picture straight away before losing time. I think are you getting the CT scan picture?
Yeah.
Yes, sir. We are seeing. Yeah.
You are getting it?
We are getting it, sir. Yeah.
See, again, I am a man who would like to look at what 90% of the people do 90% of the time in 90% of the centers in the country. Most of the times, if you remember right, all of us get an access to one film like this. I agree with having the disk, running the Osiris software and all that, but in a routine, on a routine day, in a routine case, this is what you will get, and you will have to make the most out of this. You can see the first cut here. Can you see that? Hello?
Yes, sir. Yeah. We
Can
are with
see
you.
the first
Please.
cut? Yeah.
Yeah.
This is the septum. You can see the septum again here. You can see a polyp here in the right nostril towards the cribriform plate.
Yes, sir.
And then you see the frontal sinuses appearing for the first time.
Yeah.
The septum is little deviated to the left side, a high deviation, but otherwise seems to be a reasonably good space. In the next cut, you can actually see the frontal sinuses. You can also see the thick beak starting here. Yeah?
Yes.
You can
yeah.
see the 2 frontal sinuses are roughly equally pneumatized. The right one is slightly smaller. The left one is slightly bigger. Correct?
Yes, sir. Yeah.
From this beak, you move to the next cut. The beak is becoming thinner.
Yes, sir. Yeah.
And then the beak is about to disappear in this cut.
Yeah.
So this would be our frontal recess area. We are approaching that. You can
Yes,
see
sir.
the septum here is deviated now more towards the right, which is making the right frontal sinus small posteriorly,
Yeah.
and it is big on the left side.
Yes. sir.
And you can also see a small agarnasi cell now here, which means I will have a little difficulty in getting into the right frontal sinus.
Yes.
The
yes.
left will be a lot easier, right?
Yes, sir.
Second, this next, you can see here, this is our frontal sinuses, and always remember, the moment the maxillary sinuses start appearing, the frontal sinus will start disappearing. Okay?
Yes,
So, yeah. So this is what you can see here also. So the next thing that I want to talk about, as you keep on going posteriorly, you are seeing the Kennedy's nipple here. Can you
Yes,
see
sir.
this?
Yes.
So this is the Kennedy's nipple, and you look at the orbit, you can see the ocular muscles. You see the superior oblique muscle, it is always pointing towards the Kennedy's nipple, and that is going to show my anterior ethmoid artery. And if you see the anterior ethmoid artery in this case is running almost flush with the skull base. It is not hanging on a mesentery. Okay?
Yes, sir. Yes,
So when
sir.
the
Yeah.
anterior ethmoid artery is hugging flush on the skull base, it also means that your supraorbital cell may not be very well pneumatized. And the cell which is anterior to the anterior ethmoid artery would be the supraorbital cell. So these are not the frontal sinuses. In fact, the moment maxillary sinus appears, you can be sure that the frontal sinus starts disappearing now.
Disappear.
And what you are seeing is a supraorbital cell. right?
Yeah.
Now as I go posteriorly from the anterethmoid artery, the skull base, which is W-shaped, is slowly becoming a shallow W, shallower W, and then it becomes a gentle U-shaped curve. The moment it becomes a gentle U or a shallow U, you can be sure that you are in the posterior ethmoids. Fortunately for me, the posterior ethmoids appear quite roomy. Because it's a whiteout sinusitis or extensive allergic fungal sinusitis, I may not be able to appreciate the superior turbinates very well, though I can appreciate a little bit here. And remember, in the anterethmoids, the maxillary sinuses are quadrigonal in shape. The moment we come down to the posterior ethmoids, the maxillary sinuses start becoming oval in shape. Look at the orbits. The orbits in the anterethmoid are big and round. The orbits in the posterior ethmoid become much smaller and again quadrigonal. So these are some of the features. In some other cases, you can clearly make out the middle turbinate, which has a vertical attachment, now going and or becoming horizontal, which you may not be able to appreciate in whiteout sinuses. As we go posteriorly in the posterior ethmoid, as you keep on looking at the septum, see, you can see the septum straight here. You can see the septum straight here. The moment you see here, now the septum is branching out into two bony partitions. And in the next cut, you can see that the bony partitions are complete. From the septum, like the bird's wings, the two things go here. Whenever we talk of wings, we talk of the sphenoid bone. So the moment the septum bifurcates into these two, we are plumb in the sphenoid. And in this sphenoid, you can see two horizontal partitions, which clearly shows that on the right side, I have a big onode cell, and on the left side, I have a small onode cell. The moment I have this onode cell, which is named after the Hungarian onode, I have to keep bothering about the optic now. Now look at the sphenoid again here. You can see there is a good lateral recess, which is developed on the left side. There is no lateral recess on the right side. Fortunately, there seems to be no dehiscence of the wall of the sphenoid, which means the optic nerve and carotid are not dehiscent.
Sir,
To summarize,
excuse,
yes.
sir, you are blocking the view of CT, sir.
Sorry.
Yeah.
Sorry.
Yes. Yeah.
So, to summarize my reading of the CT, because Durga Prasad,
Sir.
I basically want to always represent the medium surgeons, a lot of us who do FES on a regular basis. So looking at this one single film, before starting the case, my summary is, there is a left high deviation, there is a big polyp near the cribriform at the higher level.
Yes.
The two frontal sinuses are well pneumatized, well developed, no agenesis, but the right frontal is much smaller than the left. And the drainage pathway to the right frontal will be much more narrower than the left. The anterethmoid artery is running on the skull base. The posterior ethmoids are well developed, and the sphenoid has a lateral recess on the left side. And I have two onode cells in the sphenoid, a larger one on the right side, a smaller one on the left side. And we have a small infraorbital cell. Hello?
Dr. Gopal Sharma needs to mute his mic. Good morning, Deepak sir. Simab.
Hi, Simab.
Sir, wonderful.
You're all early waiting for your lecture.
I must thank you to have started the case with a OSA patient also. Sorry,
Yes.
but I couldn't resist commenting that.
Yeah. Dhanraj is very much here with me.
Wonderful.
And he's also saying a hi. We don't have the
Hi,
luxury of a
Dhanraj.
hand mic today. Yeah.
Hi, Dhanraj.
Hi, Simab.
So let me
Hello.
start the case.
Good morning, Simab. Good
Yeah.
morning, Dr.
Morning,
Deepak sir.
Yeah, morning.
Morning, Sudhir.
Sir, need me. Yes, sir. Sir, correct course. Hello.
Deepak, this is Dr. Bhalera from Pune.
Yes.
Yeah,
Mic.
Sir, we would like you to highlight about some pre-operative, basically preparations
Mic, sorry.
also.
Mic. Hello.
What preparations you do before you take the patient for surgery? I mean, what course of antibiotics you give steroids, you give INS.
Hello.
How many days you wait? What exactly?
Hello. I cannot hear you. Hello. Hello.
Hello.
Hello.
Good morning, Deepak bhai.
अरे मॉर्निंग संजय भाई, कैसे हो?
बढ़िया बढ़िया.
लॉन्ग टाइम नो सी. हाँ,
We are enjoying your demonstration.
अरे बॉस. So this patient, I didn't talk about the disease at all because in CT scan I spoke more about the anatomy. Debrider Fatima. There is a big polyp. Sometimes, the polyp will be so big that you cannot inject or. So let us start with the debrider looking up towards God. Actually, Dr. Durga Prasad asked many knowledgeable questions because nowadays we need to know these things. In this step, as much as possible, the endeavor would be not to touch the normal mucosa and debride only the polyp.
Can you hear me, Dr. Deepak?
Yes.
Yeah, this is Dr. Bhalera from Pune. Good morning, sir.
Hello, Bhalerao.
So I would like that you should highlight about the pre-operative preparations also in such extensive polyposis cases.
Actually,
Like
to be honest with you,
antibiotics,
Bhalerao, in my private practice,
Yes, sir.
I'm left with very little time for pre-operative preparations the way it is mentioned. But what I can tell you, whenever I have a time to list the case, I do give them a short course of steroids and then, antibiotics.
Okay.
But most
How many days
important
steroids?
here,
How many
the
days
most-
steroids?
maybe about 2-3 days, maximum 1 week.
Okay.
Many of them are diabetics nowadays, Balarao.
Yes.
So even the steroids, I cannot give it for a very long time.
Yes.
But if we have to give maybe maximum 1 week.
Okay. And what about the INS? Intranasal steroids, sprays?
Intranasal sprays do not help much.
Okay. Sir.
If you ask me, it is the oral steroids. And again, see, this is our Dr. N.S. Chandrasekhar's pack. The moment I see the pack, as a private practitioner, I am happy because now the coina is open. So
Yes,
no
sir.
matter whatever is my clearance, the patient can breathe. He won't curse me after the surgery.
Very true.
And again, Dr. N.S. Chandrasekhar will speak at the end of the thing about the preparation. But what I do here is, one is I request the anesthetist to give a dose of tranexamic acid. Number one, I give a lot of importance to heart rate. If the heart rate is at 60, usually the oozing is less.
Okay. So do you
And,
prefer giving beta blockers preoperatively?
Yeah. No, I don't give beta blockers preoperatively. But if my anesthetist gives it before, I don't know about that. What I insist on in Trenostat, that is one, or any tranexamic acid injection. Number two, keeping the heart rate at 60, which is very important to me. If it is possible, the systolic blood pressure at 90, then I give a good head and tilt. And even in the head and tilt, what I do is, I generally not like to use a head ring, but in case the head ring is put, then I would, tilt the neck a little bit to keep the whole body horizontal, and then the overall position to be put in the reverse Trendelenburg position between 15 to 30 degrees, at least 15 degrees.
Okay, sir.
And I pack the nose with maybe 3 to 5 ampules of adrenaline in 30 ml of xylocaine, and I inject. See, actually, previously we all used to inject. Now all the leading FET surgeons like Satish Jain and Janki Ram, they have been using frank adrenaline, and they are doing very well. But somehow I am still a little apprehensive about that. I don't know, with injections, I have not had any problem with any patient, probably because my anesthetists are excellent. I must thank Dr. Chandrasekhar because he never refuses a case, So now I am able to see the axilla of the turbinate, I think. So I could not inject here. I think I am able to see the axilla.
Yes, sir. Yes, sir.
Now I am able to see. I was not able to see before. So probably I'll inject a little here. Adaf Babu. Local picture is okay?
Beautiful.
Yeah. I think all credit should go to Nayakanuru Shivshankarappa Chandrasekhar. Look at the field he has given me.
Yes.
When your anesthetist is extraordinary, the surgeon who is ordinary also starts appearing a little more than ordinary.
The comfort level matters, sir.
Yes. Dressing forceps. So I injected a little bit there. I need to debride some more polyps to get hold of some anatomical landmarks. I'm feeling a little reassured because I've got 2 of my landmarks now. One is the coina. That according to me is the most important and the consistent landmark, which is always there, no matter even if it's 7th revision or 8th revision or whatever. So I've got the first landmark, that is the upper border of the coina. Second, I've got the inferior turbinate. I can see this fully now, right? Debrider?
Yes, sir.
I will try to see if I can find the middle turbinate, because these extensive polyposis cases, it is difficult to find the middle turbinate.
Hi, Dr. Deepak. Hello.
Yes.
Hi, Dr. Deepak. Vikas here, Bombay.
Hi.
Wonderful.
Hi, boss.
Wonderful to see you.
Arey, boss. It's a long time, this COVID.
Yes.
We were missing all these workshops.
Yes. My question to you, if you find the middle turbinate, will you preserve it?
It depends on the middle turbinate, how it is in the end, My first guru in FES, Dr. Tulsi Das, believes that if you remove the middle turbinate, then, the recurrence rates are less or whatever.
And you know that I believe the same in extensive polyposis like this.
Absolutely. Yeah, Vikas, correct, yes. You believe the same, absolutely. Vikas, my teacher in FETS has been Satish Jain. And I'm not a thinker, I just follow something very blindly till my guru tells me do something else. I'm not an innovative fellow. Ribbon goes, please. So I just keep doing what keeps doing, and as I keep on telling, I want to really show demos to the medium surgeons, like, you have a little oozing like this. How do you manage? How do you manage with a single cut? Because most of the times, the CT scan we get are all one single sheet of film.
Absolutely correct.
Yeah, so I would like to do what 90% of the medium surgeons do. most of the times, which can be replicable. So I do agree with you, and see, I have tremendous reverence for Dr. Tulsi Das as well. He was my first guru in endoscopic sinus surgery along with V. Anand. Of course, Satish Jain has taught me, quite a bit.
Good morning, Dr. Deepak sir. Vikram here from Mumbai.
Hi, Vikram.
Sir, there was a little pus that you just sucked out.
Yes.
Wouldn't you want to send it for culture?
Yeah, why not? Swab, please.
And
That's a great idea, Vikram. I'll take a swab right away.
and wouldn't you want to send the polyp sample also for histopath? For
That I will take the last one. Sometimes something which is suspicious, probably worth taking a space. Wait, give me the dressing forceps first.
Because there is a line of thinking that if the polyps show high eosinophil count,
Yes.
then they respond very well to immunotherapy and recurrence rates are almost nil.
Yes. In fact,
So my
Dr.
next
Dhanraj
question would
believes in
be-
the same thing. Now we know in almost all polyp cases, we do a good allergy test as well, because we know that this is a medical disease. No? 45-degree forceps.
Thank you, sir.
Your point is valid, Vikram. Your point is valid. Yeah. We will take a biopsy here. Okay.
Hello, Vikram, good morning.
Yeah.
Yeah, good morning.
Good morning, Balerao here from Pune, Sudhir.
Yeah.
Vikram, I would like to say that
Yeah.
the biopsies, basically, if you want to send it, why not send it the polyps which are from the sinuses, not in the nasal
In fact,
cavity?
if I send a biopsy, definitely I don't want to send from a pale polyp.
Yes,
I
yes.
want to send something which is more reddish, congested with a irregular surface.
Yes, very true,
Which is
sir.
why I chose this area.
Yeah.
Because the whole idea is not only about eosinophils, occasionally you can get in an early malignancy also, especially in people of this age.
That is the reason when I saw the pus, that is when I
Debrider?
requested sir to take not only the swab, but also the polypoidal mucosa surrounding that area.
Yes. I think their points are valid,
Dr. Deepak, you see some polyps arising from the septum.
Yes.
So how do
1
we
minute, I still left the polyp from the septum.
Yeah.
You want me to take a biopsy from the polyp from the septum, is it?
No. I'm saying, how do we explain in polyposis the polyps arising from that part of the septum? Because if it is ethmoturbinal, then it should not arise from septum. But many cases we see.
No, not necessarily. Not necessarily in extensive polyposis. See, previously there was this theory of polypogenic area.
Correct.
That polyps would come only from particular areas.
Correct.
I think that myth is now gone, actually. Isn't it? Now polyps can really be seen anywhere, and we have seen in many cases the polyps coming from the septum.
Correct.
That seems to be the middle turbinate,
Right.
which is partly destroyed by the polyp. It's very fragile. So maybe eventually I'll go with Vikas and take out that portion in this. There is something coming here also from the septum. So that also we'll address. I'll touch it last because I feel it will lose and coming the way of my surgery. Ribbon gauze, one more.
Deepak sir, good morning. This is Pradeep from Mozur.
Hi Pradeep, Gunam, how are you?
Fine, sir.
You are an excellent skull-based surgeon yourself. You are a fantastic skull-based surgeon doing tremendous work in Hosur. I know that.
Thank you, sir.
Yeah.
Thank you, sir. Thank you.
Yeah.
Sir, what is the take on the Cribriform polyps, where you don't have a polyp in the middle turbinate at all?
What is the take? What is the take on? What is the take on?
Yes. What is the take on the Cribriform plate polyps? Cribriform plate.
Cribriform
which is
plate.
coming from the skull base. The
Yes.
polyps you see exclusively which is coming from the skull base region.
Yeah,
You
yeah,
don't
yeah.
see anything in the middle turbinate or the middle meatal area.
It's like a polyp anywhere else as well.
Okay.
Only thing is you have to be gingerly in removing it so that you don't create a CSF leak. And number two, you also don't, damage it so much that the olfaction gets affected. In fact, Daniel Simmons and Nick Jones, they feel that polyp in that area should be left alone if the steroid spray can reach that area. But as far as I am concerned, I would definitely debride it to the level of the safety and then probably give the steroid spray.
How about the recurrence rate, sir?
Recurrence, is it?
Yeah.
Recurrence rates are there with everybody. See, now they have found that dupilumab, after it has come, it is working well and bringing down, making the polyps disappear. Ultimately, Pradeep, this ethmoidal polyposis is a medical disease.
Yeah,
What we are doing right now is only a compromised treatment because this is all what we know at this point of time. But I am sure eventually the immunomodulators and treating the cause of the polyps, including allergy as Vikram mentioned, would be the ultimate solution. Not the surgery what I am demonstrating today. This is only effective in making the medication reach the sinus floors to slow down the recurrence and reduce the rates of recurrence in the polyp. If any surgeon in the world claims that he can do a surgery without getting a recurrence in ethmoidal polyp, he is living in a Alice's wonderland. Yeah.
Thank you, sir.
Good morning, sir. Kaushal here.
Hi, Kaushal.
Can I ask you a question, sir?
Why not, boss? When everybody is asking why we have banned you, tell me.
Sir, what is your take on using navigation in these cases? Do you think it's more effective than using our routine methods?
Boss, navigation is like a Google map.
Yes.
If you have it, if it is cost effective, use it in every case. Nothing wrong. But again, in our country, with the economics being what it is, we can't use it so frequently, isn't it?
Right. Sir.
It's like in a chronic ear or in any ear disease. Before operating, if you ask me mandatorily, would you like to do a CT scan? Why not? Isn't it?
Yes.
If you have navigation, if you have access and it is cost effective on per case basis, connect it the way you connect your monitors, debriders, coablators, everything. Isn't it?
Yes.
It's okay to say that anatomy is important, all that is fine. But if I have a navigation, if my setup allows me to use it in every case, I will get it connected in every case because definitely it is going to reduce the rate of complications.
True.
Isn't it?
Right.
Yeah,
Sir,
I'm for it.
Sir, am I audible, sir?
Yes, very much.
Yeah. Like you were telling about recurrence, sir. In one CME, I asked a surgeon, what will you assure the patient when you are doing this polypectomy and FES? Then he said, I assure him of a recurrence.
Yes, in fact, to quote Milind Kirtane, sir, he would always say that recurrence is more of a rule rather than an exception. I will also quote what Professor Madhavaya, my teacher, used to say, which Vijendra would always repeat. In medico-surgical treatment, there cannot be any warranty or guarantee. Isn't it? The endeavor is to make the patient better. In fact, our books always say, debrider, our books always say that a physician's job is always cure, mostly console, and occasionally cure the patient.
Yes, sir.
Isn't it?
Yes, sir. Yeah.
Absolutely.
Now, the discussion about middle turbinate, sir.
Yes.
Preserving middle turbinate and taking it off. Of course, surgery would be easy and removing the polypectomy and other procedure might be easy. But what are the pros and cons of preserving a middle turbinate and taking off a middle turbinate?
What are the
Pros and
volume?
cons.
Guru.
Would you like
the
to,
volume and self
if possible, would you like to preserve it?
हाँ ये थोड़ा नजदीक लाओगे आप I always want to preserve the turbinate as much as possible unless it is very flappy, then only no. Otherwise I would like to preserve the middle turbinate because it's an important landmark. Because see, ethmoidal polyp again, you don't know when you will have to do a revision surgery, isn't it? So if it is possible, preserve it.
Okay.
But
And
then
in
in
a
a
case,
yeah,
and in a case of recurrence, as you were telling, Koina is the most important landmark.
yes,
Suppose along the floor, if you debride the polypi, in a case
Yes.
of recurrence, would you prefer coming from posterior to anterior like Weigand's method?
yeah, it depends. See now, for example, if the polyp is not giving you space to go posterior, how you will go posterior? Wherever you can see, remember one thing. In the dictum of sinus surgery, it is always better that you go, anterior to posterior. Occasionally, you can come from posterior to anterior. The only thing is the polyps have to allow you to go posterior. See here, I can only go posterior if I remove this polyp. See, now I see that polyp. Huh?
That's what, sir. Suppose we do polypectomy along the floor, you get some space. Then would you prefer to come from posterior to anterior?
Yes, that is why I told you, no, even on the other side you saw me. I first want to see the coina.
Okay.
Because coina is a very stable landmark. It is present even in the 6th revision, 7th revision, 8th revision cases, isn't it?
Yes, sir. And in our experience, sir, the steroids preoperatively are highly helpful. And
Yes.
even if the patient is diabetic, we titrate insulin at least temporarily for a few days, and
Yes.
then give steroids and then go ahead, sir. We are happy with steroids
No, sir,
before surgery.
I totally agree with it, sir, because in an ideal situation, just like how I answered Kaushal about the navigation system, in the ideal situation, I would like to prepare each of these patients for 3 weeks. But in private practice, in life practically, many times it doesn't happen.
So the medial structure that you are currently dissecting, could it be part of the middle turbinate?
It is the polypoid portion of the middle turbinate.
Okay.
Absolutely. You are right.
And so
then,
you mentioned a little while back that, your leading guru is Satish Jain, but what he does is, on the other side, before coming to this side.
Yes.
What I missed, which is characteristic of Satish Jain, is he gives a warm saline flush before packing.
Warm saline, is it?
Yeah.
Satish doesn't believe in warm saline as far as I know.
No, flush to control the heat
Janaki uses hot saline.
So, sir,
I guess in this COVID, I might have lost touch, but Satish doesn't advocate warm saline. Debrider?
Deepak, one observation.
Yes.
We have seen, polyps arising from the septum, from the middle turbinate.
Yes.
Have you observed polyps arising from the inferior turbinate?
Sometimes, yes.
Okay.
We observed, sir.
Yes.
There were, it is
Same
basically
here.
edematous change. Edematous change of the mucosa. And there was question about the Cribriform plate, sir. We encountered a few cases where there was polypoid mucosa from the Cribriform plate. Considering it is not a tumor, we need not extensively do that, but we can do at least partial polypectomy and substitute with steroids. Usually they come down, sir. They do not, and it is not a drainage pathway also. It doesn't impede any drainage. So we didn't encounter problems,
it is not an area where medicine cannot reach also.
Yes,
isn't it?
Yeah.
The moment you put the spray, it touches that area only.
Yeah.
So in fact, Dr. David Kennedy has proposed a hypothesis as to why the polyps arise mainly from the ethmoidal mucosa.
Ribbon gauze, give me the regular saline wash. But at the end of the day, whatever surgery we are doing right now is definitely not the or complete treatment. Can you see the middle turbinate? See, when you remove the polyps, so much of it is destroyed.
Yes, sir. Yeah.
Yeah. See, this is the first bony structure of the middle turbinate I am seeing. You can give it with the needle only. That's also not a problem. Yeah.
Many times it turns leafy, sir, because of the
Yes.
polyps.
Yeah. And this is a case of extensive polyps.
Yes.
So, you know.
Dr. Deepak, can I add a few things?
Arre, why not, boss?
I'm just.
Boss, this is a group discussion.
Right.
See, even if you don't learn how to do FES, at least you will learn how not to do FES with my demonstration.
Correct.
Don't worry about that. Just go ahead.
No, so
yeah, these questions don't disturb me at all. No.
So
Yeah.
on the statement that we guarantee a recurrence to the patient, that's absolutely correct. But like Kaushal said, can you use navigation? If navigation is used and
Yes.
if you remove this leafy middle turbinate,
Yes.
if you remove each and every air cell at the skull base, we can
Yes.
at least guarantee that a revision surgery will not be required on the patient. Obviously, recurrence will be there. That
Vikas Agarwal, I admire your confidence. I just now said my teacher, Professor Madhavaya, said no guarantee, warranty in treatment. You are using the word guarantee, hats off to you. But I don't have that guts.
So,
Sir,
so if all the air cells are already removed, then what a future surgeon can actually, remove later? That's what the question is.
Pata nahi, boss. Use the word guarantee. I think somebody's mic is accidentally on or whatever. So guarantee is something I can't, boss. Even on a following a tonsillectomy.
Sir, even if you remove all the air cells very meticulously, there
Right.
is some gap there. And once the mucosa covers it, from there, just like maxillary sinus, there will be a single polyp from the ethmoidal area. We have seen that, sir. So there is no guarantee at all.
Debridement.
There is no guarantee at all.
Yeah.
No, I mean, Vikas is very brave, sir. I can't. See, following a regular tonsillectomy, I can't guarantee a patient he won't get throat pain again. He may not get an attack of tonsillitis, but I've seen them getting pharyngitis, simple like that. So I still believe that the moment guarantee and warranty comes in medical, this thing, I don't know. I cannot assure that. No.
A few came back with saying that they had recurrence, sir. They were lingual tonsils. Very
Yes.
hypertrophy.
Yes, yes.
So
Something
even
like that.
there we cannot assure.
Because see, science is ultimately a quest. And let's not mistake, Vikas is a fantastic surgeon. I've seen his surgeries. I've seen him removing the polyp and removing this thing. Very good, this thing. And I don't disagree with his viewpoint or something.
Hello, Dr. Deepak.
Yes. Ball probe. See, I can't see the uncinate the way the conventional way it is. Can you see this?
Hello.
The uncinate is all destroyed. 40-degree blade. Fatima.
Hello.
Yes. Hello, Janki.
Hello.
Yes. Debrider.
Hello.
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 Now I'm using a 40-degree blade.
Yeah, I am talking. You're...
Yeah.
It's coming now.
Now I could actually, expose one sinus.
Hello.
Yes.
Hello. Hello. Am I audible?
Good
Hello.
morning, Deepak. This is Dr. Arkeja from Ranchi.
Yes, you are
Hello, hello.
Hello, sir.
How are you, boss?
Fine, thank you. From Ranchi, Jharkhand.
Yes, I know. We were there for the conference, yaar.
Yeah. We have met several
Yeah.
times.
Sir, am I audible?
Me, Dr. Bharti Madam and Dhanraj were there even during the wave.
Yes.
We were there in Ranchi.
Yeah.
Hello.
Well begun, sir. Carry
Yeah,
on. We are just
Dr.
here.
Deepak, good evening.
Yeah.
Hello.
Dr. Deepak,
Keda
good
Meda
evening.
section. Yeah.
Hello.
I have now scored 1 mark out of 8. The maxillary sinus on the right side is reasonably exposed now.
Dr. Deepak, can you hear me?
Yes, very much.
This is Dr. Munka.
You are from US.
Yeah.
You are in US right now, no?
Hello.
Yeah, right.
You are
So
not
I
in
joined-
Ranchi. You are not in Bokaro. You are in US. I
sir.
know that.
Yeah, I'm in
You
Austin.
logged in from there.
Yeah.
अरे
That's why
boss,
I'm
आप तो
able to
पंटर
talk
हो
to you.
boss.
That's 11 p.m. here.
Yes.
Yes. You said about Ranchi. It was our pleasure that some of you at least could come. Many of
Yes,
us
we will always feel happy that we came.
Yeah.
You know, me, Dhanraj and Bharti, straight grasper.
No, everybody wanted to come. Kausal, Samir, everybody wanted to come, but because of some reasons they couldn't.
Yes.
So,
Remote.
But it was very well organized.
Now it's
thanks.
audible.
Because of all
Now
you
it's
people
audible.
joined, it became good.
Yes. So even with such an infected case, look at the field my anesthetist has given me.
Now it's
You can
audible.
see the frank pus in the maxillary sinus. See here. Even with this, look at the field Dr. Chandrasekhar has given me. Wash 50 ml syringe.
Bluetooth speaker on enter the ground.
Probably this is the bulla. Hello?
Dr. Deepak, for the late
Yes.
joining, the
Wash.
people who have just joined, can you
Yes.
give a brief summary about what we are going to do and what we have
No,
done? so
basically AFRS, wash.
Hello.
Wash. You should do it with both the hands, full force. I don't want to just give a gentle irrigation.
So this looks more like a AFRS case.
Wash. It is AFRS, yes. It's an AFRS case.
And now there is a-
Bilateral. Wash both hands. Press forcefully.
And now, apart from the type 1 hypersensitivity, there is also a type 3 hypersensitivity phenomena happening.
Straight
And the
circulatory
staphylococcal super antigen theory, that is why the pus culture now becomes important.
Yes.
Hello. Hello.
Yes.
Hello.
Yes. Teda meda section, please.
Sir, am I audible?
Yes.
Sir, Dr. Janigram sir wants to talk, sir.
Yeah. Connect to the hero, the star.
Sir. Yes. Sorry, sir.
Palaiva, good morning.
Hello, Dr. Deepak ji.
Palaiva, good morning.
How are you?
With coarse
Palaiva,
tremors.
good morning.
Now that you are on the mic and I am demonstrating a fest, my hands will develop tremors.
Sir, you are humble. Actually, you are super, doing great.
No. So you are
So
showing
happy to
two
see
cases. You are showing two cases today. And see, somebody asked question about warm saline. I want you to answer that.
Yeah. Actually, basically, warm saline, I use it both in FES as well as in skull-based surgery.
Yes.
What warm saline does at around 40 degrees, it controls bleeding. Hemostasis is very good with warm saline. And there was a controversy that it affects the ciliary motility. It's been disproven. There is nothing like that. So I generally use saline, warm saline, both in FES as well as in skull-based surgery.
Yeah. So
beautiful, wonderful demonstration, sir. Wonderful.
What is there, boss? We are all waiting for the afternoon. And Vijendra sir said that very clearly. Vijendra sir said, the hero in the afternoon is going to show 2 cases.
Sir, he is my guru, sir. And you are K. Balachandra of ENT.
No. The stardom to the masterclass. Bus.
Dr. Janki, can I ask you a question?
Yeah, sure.
What works better in your hands? 29 ampules of adrenaline, which you said once.
Sir, you're not audible. 1 second. Can you make this more audible, please? Yes, please. Why is it not audible? Yeah. Yes, sir. Please carry on.
40 degree forceps.
A lot of warm saline.
This looks like the uncinate remnant. Debrider. Yeah. You can ask the question to Janki. Yeah. Go ahead.
Yes, sir.
Dr. Janki, what works better in your hand? Adrenaline or warm saline?
What or warm saline?
Adrenaline or warm saline?
Adrenaline. Oh, both. A combination of both. I use 1 in 1,000 adrenaline, unquantified, undiluted adrenaline. This has been recommended by Professor Stamberger when I got trained by him. And warm saline was recommended to me by Professor Amin Kassam. So I think both of them are inventors, and there is no doubt that both works wonders in my hands. And it should work wonders in every hand. Actually, they are not doing it. So whenever I say, they're saying, oh my God, I will not use, I'll use 1 in 10,000, 1 in 1 lakh. I mean, basically the concept is never infiltrate. Infiltration of adrenaline, it's because it's a vascular area. So what happens is when you infiltrate, there's erratic absorption. So it increases the pulse rate. But when you use adrenaline, see, there was a small controversy, I think in Barcelona, where they said, why are you using so much of adrenaline? And for that, Kassam says, or Stamberger says, adrenaline prevents its own absorption. So if you use 1 or 10 or 50, it doesn't matter. But it causes intense vasoconstriction, thus producing it prevents its own absorption. So topical can be used unquantified, undiluted.
Dr. Janki, I have another question. This is Vikram from Mumbai.
Hi, Dr. Vikram. How are you?
What is your concept of maximal medical therapy before operating a polyp case?
Maximal medical therapy first of all, let us understand that both ethmoidal polyps and antroconal polyps are not treated medically. Once you have a polyp, you should operate. So this is basic concept. And you can see any number of Curl's video, Professor Curl from Draft Center, that if you go on treating it with steroids, then you can convert it into fungal sinusitis. So this is a concept which was released by Professor Draft. Now, having said that, if you have ethmoidal polyp, then it's better to increase the field of surgery. Surgery. So you can give steroids. There are 3 doses. Of course, Dr. Deepak ji is operating. I don't want to disturb him. He might.
Hey, no. See, let the discussion go on. In between, I will tell you when I'm doing the steps. You go ahead. See, ultimately, masterclass is all about knowledge, not who is the master. No, go ahead.
Wonderful.
Yeah.
So, so steroids can be given in 3 different doses: low dose, medium dose, and high dose. Medium dose is 30 milligrams per day. That is 0.5 milligram per kg body weight over a period of 7 days to 10 days. There's a little controversy regarding how long, but international consensus says 7 to 10 days, along with intranasal corticosteroid sprays. And see, corticosteroids form the main line of medical management. Apart from the biologics right now, the biologics right now are coming up in a big way. Dupilumab, injections, but they are a little expensive. But definitely, I think steroids will hold good because it's basically
11 o'clock, correct?
immune modulated disease.
11 o'clock, correct? Sir. Very good field.
Beautiful surgery, sir. Wonderful.
Illa, sir, this infected case, see, actually, Vishwas Vijay was supposed to demonstrate.
See,
and he had a
if we want
fever.
to show a non-infected, straightforward case, we will not call Dr. Deepak ji.
Coming from the Talaiva, this is really
We need to see
now
a
I'm
tough,
floating.
a person fighting with a tough villain rather than with a meek villain.
Ballproof, yeah. But one thing I must tell Janki,
Yeah.
with Janki or Satish at the other end of the mic and we demonstrating FES, is really unnerving for anybody. The awesome reputation you guys have built up with FES and your skull-based surgeries. 40-degree blade? Huh?
Sir, one point I want to add regarding the middle turbinate. I heard your discussion.
Yeah, see, I could find the maxillary here again. In such extensive polyps, we cannot look at the landmarks the typical way. And how Janaki beautifully takes out the uncinate. Here the uncinate is destroyed, the horizontal portion.
Yeah.
So I can't show that honestly. So two magnum opus cases you are showing today, Janki.
Yeah, yes, sir. It's going
You are
to be.
showing it from Trichy or from Hyderabad?
Sir, from Trichy today.
Okay.
And tomorrow from Hyderabad, if you permit me.
Yes.
Good morning,
It's
Dr.
full of
Janki.
pus.
Dr. Janki?
Yes.
Good morning,
good
sir.
morning. This is Dr. Bhalerao from Pune.
Yes.
Hi, sir. Dr. Balarao, how are you, sir?
I'm fine. How are you, sir?
Oh, doing fine with your blessing, sir.
So one question to you.
Yep.
When there is a contraindication to use adrenaline,
Yep.
then what do you do?
Okay. See, basically, that's a good question. If the patient has got a myocardial infarction previously, or high risk, very high risk, then my anesthetist says don't use adrenaline. That's the only contraindication.
50 ml
In fact, for
push with
asthma,
both hands.
it's a very good actually. It's a drug of choice for asthma. So we use a lot more of adrenaline in asthma, which is the commonest association with polyposis. But for patients who have high risk cardiac
Wash again.
we generally don't use adrenaline. And then what happens is we bank on warm saline. So warm saline is the trump card for me when it's so we don't use that because my
both hands.
answer says no.
Press hard.
Good question.
Okay, the only warm saline you're using it.
Yes, 40 degrees.
Okay.
You will see that we are doing that. I mean, we have been doing this for a long time now, around 12, 13 years now.
One more wash.
We've never had any problems post-operatively or intraoperatively. And in fact, see, for example, if the scope fogs, this is what I tell my fellows. If your scope fogs very often, your time will increase and you will get annoyed. So the best way, in fact, nowadays, if you see me operating, I never get my scope out and anti-fog at all. We generally don't even anti-fog it. It's all with saline, which my assistant washes. So there are two people operating. One is my assistant and one is me. And I keep operating. And if it gets fog, just irrigate with warm saline. It reduces the. So what are the advantages? Number one, it reduces the number of times it fogs. Number two is the field becomes clear because of lesser bleeding. And so, I mean, the debrider has got a suction already. So no problem at all.
Okay. And what is your take on beta blockers?
Beta blockers, yes, we definitely use, but the only contraindication again is an asthmatic. But we use atenolol 25 milligrams the day before the surgery, as well as 45 minutes before the surgery. But all these are decisions taken by the individual anesthetist. There are some anesthetists who don't give it, but in our center, we do give atenolol 25 milligrams, but not on long term, like 3-4 days we don't give. We give it on the day and just one day before.
Okay. Thank you, sir.
Hi, Dr. Janki.
Hi. Oh, Dr. Prakash ji from USA.
Yeah. Hi.
So
Good
nice.
evening.
Actually, Yeah.
Yeah. About your discussion, I was listening about the warm saline.
Yep.
I have seen you since ages, I think last 10 years or so.
Yeah.
You have been always using it for the angiofibromas with severe bleeding.
Action.
And first time when I was moderating you, probably we were at Raipur.
One more
That
ribbon,
time,
guys.
we thought you are going to pack it. And you didn't have to do anything.
Yeah.
So the message we always propagate that warm saline is probably one of the best thing. No chance of any reaction or contraindications with the
Nothing.
adrenaline. Don't need a hypotensive anesthesia. And
Yeah.
otherwise life becomes much more easier. Even the
Yes.
scope, you don't have to wipe it again and again.
I will
So
tell you a
this was-
small history what Amin used to say, Professor Amin used to say. When we used to go to the barbers, where was this warm saline first, used? It was used in the barber shop. So whenever they shave, they used to have a small cut. And for that, they used to take that warm saline and just pat that area. And it used to stop. So that's where it was invented. And because it activates the extrinsic pathway of hemostasis, thus producing, stoppage of blood. So that is how it acts. Some people think it's a vasodilator. No, when you use hot saline, it's a vasodilator. Warm saline is not a vasodilator.
Right.
Janki,
Yeah.
can I interrupt a little bit?
Please, sir, you are the hero.
Yeah.
Please.
I just want to show the audience, the moment you open up the sinus, see how the pus is now coming out, tracking itself out.
Sir, I have a question.
45-degree forceps, yeah. You can ask questions to Janki as well. Please don't think you are interrupting my surgery at all. No.
No, sir, I just have a question. I'm Dr. Meenakshi from Chennai.
Yeah.
And I'd like to ask you what the Mirocell sponges that you have used, sir.
What? What is
The
that?
Mirocell sponges that you had kept in the sinuses.
Yeah,
You had
Mirocell, yeah, correct.
one
This is a regular net
in the
cell.
ethmoid as
This is
well.
a regular net cell, which we use for nasal packing. Yeah.
So there is one disadvantage of using this Mirocell.
Yes.
That is, I have found maybe one case where this Mirocell was used and then they didn't have a count. It's like a cotton ball. And after 3 weeks, the patient came to us with Mirocell inside. And this is one small disadvantage. I think we should have.
Janki, this can happen with a small piece of ribbon gauze also.
No, what?
See, ultimately, the fault is not of the Mirocell.
Not with the
The
Mirocell.
fault is of
What I
not
mean to
keeping
say
the
is that-
count.
No, what I mean to say is that whatever we use, gauze, Mirocell, whatever, I think we
Yes.
should have a little skin that is the silk thread.
Maybe that you have a valid point.
Yeah.
But leaving a Mirocell is not the fault of the Mirocell.
No, not the fault of Mirocell.
45-degree
Not the
forceps,
fault
yeah.
of the Mirocell at all. I'm talking about the fault of the surgeon only.
Yes.
Mirocell are small, cut small, and then you leave it. I saw it in
Yes.
an MRI. I'm just
Yes.
telling you.
Yeah. Now to the audience, ball probe. See, I feel this is the recessus terminalis. This one is the recessus terminalis. And I feel this is the uncinate. And probably this is the frontal pathway here.
Yeah, exactly.
Yeah. Janki, if you say exactly, then I feel elated. The master is agreeing, yes.
Lovely,
Okay.
lovely demonstration. Lovely
yeah,
demonstration.
yeah. Because these are cases where everything is destroyed due to extensive polyposis.
Yeah.
But even with the infection, with little time, we can get a reasonably good field. 45-degree forceps. Janki, you continue the question answers. It is really enlightening for me also.
See,
Please
the
continue.
one maneuver which Professor Haldipur is doing, you see here, where is he inserting that ball probe? If you look at it, it's very close to the axilla of the middle meatus. That
Yes.
is where you will never get the cribriform plate.
Debrider, yes.
So if you look at the cribriform plate starts at least around 0.75 to 1 centimeter behind the anterior attachment of the, it's not in every case, but it's better to hug the nasofrontal beak and go up as he has done. And you will definitely be inside the front.
And always give a gentle lateral tilt.
Yes, exactly. The gentle lateral tilt. Yes. Wonderful demonstration.
Probably we are in the frontal recess, Janki.
You can hear it now.
Yeah. Dr. Janaki, this is Dr. Durga Prasad from Hyderabad. Good morning. How are you? Am I audible?
Durga Prasad's discussion with my anesthetist was one of the most amazing discussions I have heard in the recent times. Surgeon asking so many questions and being 45-degree forceps and being knowledgeable about so much of knowledge about anesthesia.
Because we faced so many complications, sir.
Yes, absolutely.
That's how we learned. Yeah.
Because unlike neurosurgery and oncosurgery, the ENT surgeries are considered as routine. So patients don't accept complications kindly.
Yes, sir. Yes, sir.
So anesthetist is a very important person in our practice. And one thing I realized, the surgical complications are directly related to the oozing or hemorrhage. Because once there is a lot of oozing, you cannot see the structures. As a surgeon, you become impatient. You start assuming and trying to do the surgeries. You won't be able to appreciate the landmarks as well.
Yes.
Isn't it?
Yes.
The brighter. See, with a feel like this, I can so nicely appreciate the terminal recess and that small polypoid changes within the frontal sinus. Isn't it?
Yes, sir. Yes.
Yeah.
Dr. Janaki, are you there? I think he's not.
There is a popular saying that the success of a surgeon depends on how good his anesthetist is.
Yes.
Yes.
So I think the first session that we had today from the anesthesiologist, and the questions asked were very, very relevant for us surgeons.
45-degree forceps.
Because at the end of the day, it is the surgeon's liability,
Yes.
including that of the anesthetist. If in case any problem occurs or if there's any complication.
Yes.
So the surgeon is liable even for the anesthetist. So we need to be very vigilant and aware. And also we need to update our anesthetist with the knowledge that we have gained here, apart from our own skills that get enhanced by such, masterclass demonstrations.
See, now, this is a very important landmark in FES. I always say this. The first important landmark is the choana, the upper border. The second, if it is present, it is the inferior turbinate. If you notice, all along, we have not really done much to the inferior turbinate. It is intact. And the maxillary antrostomy concentrate on the junction of the roof of the maxillary sinus with the medial wall.
Okay.
See this. This point, I find it very, very important landmark. You draw a horizontal line and you hang around this line as you go posteriorly. You are less likely to damage the skull base.
Skull base, yes.
Okay? Especially in cases like this where you can't appreciate the landmarks.
Yes, sir.
Yeah.
Once you appreciate that, go infero-medially.
Yes. One punch.
Yes.
So I won't go directly with a debrider now. I will go with the manual instrument because manual instruments are a lot safer. So I will go medially and inferiorly like this. 45-degree forceps.
Hello.
First, I would like to palpate, take out this piece of bone here. Now I will probably debride.
Yeah, you made a very valid point, sir, particularly in uncinate process.
Yes.
When it has anomalous attachments, backbiting
Yes.
is the safest.
Yes.
So pulling it,
Yes.
backbite it, piece it and take it off. So
Dr. Deepak.
Yes.
Dr. Mandani here from Thana.
Hare, hello boss, Mandhani, tell me. Long time.
Yeah,
We used to meet at Gumkar's place also.
Yeah,
You know,
fine.
tell me, sir, tell me.
Can remember me. Yeah, there's a question from one delegate that do you routinely use omalizumab for recurrent ethmoidal polyposis? And what is the-
Omalizumab, is it?
yeah.
No, now the drug of choice is dupilumab. Dupilumab is the drug of choice.
Okay.
1 injection every month, lifelong. Cost of injection $7,000. So 5 lakhs per month, 60 lakhs. Right now,
patient-
only for Adani and Ambani. Bone
patient
punch.
might prefer, yes, sir. Patient might prefer allergy and polyps rather than injection.
Another question.
Yes.
Do you use antifungal agents in AFRS before surgery?
Yes. I am one of the believers. I use a lot of itraconazole and I have found in many revision cases also that, the itraconazole works very well.
And
I can see something yellow. So I will try the Stankiewicz sign first. I'm palpating the eye. I don't find any movement. Okay.
how many days before surgery you start?
Hello. When you see something yellow here, always you should have your antenna up.
Hello,
Okay.
from Kolkata.
Yes.
Dr. Deepak sir?
Yes, who is speaking? Utpal Jana sir, is it? Who is speaking?
No, I'm Dr. P.V. Roy.
Hello.
Hello, sir. How are you?
Hi, I am fine, sir.
Sir, I have one question.
Yes.
In a case of extensive polyposis, as is this one,
yes,
what the measures or what the precautions you are going to take to protect the anterethmoidal artery or to so that it doesn't get damaged?
What are the precautions?
You are going to take or be careful while maneuvering this part of the part of surgery, so that the anterethmoidal artery doesn't get damaged.
See, anyway, it is the intact bulla technique. It is always better to identify the frontal sinus first. If you do that, then you realize that posterior to the frontal sinus is the infraorbital cell. The supraorbital cell. And next to the posterior border would be the anterethmoid artery. So wherever possible, don't try to remove this anterior wall of the bulla. Can you see this here?
Yes, sir.
Yeah, you try to keep this intact where my merocell posterior end is there. The anterethmoid artery will be slightly posterior to this, which I will show you next. So keep this area protected. Can you see this bone?
Yes, sir.
This bone is the one which is going to protect your anterethmoid artery. So till you make space to visualize the skull base, bone punch, and very close to the lamina papricia, very close to the skull base. Don't hesitate to use manual instruments. Okay.
Sir, you were telling about medial orbital floor.
Yes.
Sir, if you draw a line from medial part of the medial orbital floor,
yes,
medially, there will likely to not likely, we are sure to get the sphenoid ostium.
See, the lamina is thinned out. Can you see this?
Yes.
See, the lamina is mobile. Right?
Yes, sir. Yeah.
Yeah, bone punch.
Sir, any tips for the frontal sinus draining medially, sir?
Yes, sir. That is what I'm doing. I'm just showing that now, right now.
Sir.
See, this was the recessus terminalis. See here, my uncinate is going up here. You can
Sir.
see the uncinate going up here, the remnant. This is the terminal recess. This is the middle
Okay.
turbinate attachment. This is the polyp in the cribriform plate area, which
Yes,
I
yes.
discussed when I started the CT scan, which
Yeah.
I'm going to touch the last. Some polyps from the septum, I'm going to again touch it last. Isn't it? See the picture now,
Yes, sir. Yeah.
isn't it? So I'll just
Okay, sir.
remove a small piece of bone now. 45-degree forceps. So this spicular bone will also go now. Because remember, you need to have a wide middle meatal antrostomy.
Yeah.
Because it's AFRS. Bone punch.
Now, intact bulla and going into frontal sinus is a safe method, sir.
Yes.
Would it be possible even with the medial drainage of frontal sinus? Or should we
Yes,
take off?
yes. See, actually, I've seen Satish, who taught me the intact bulla very well. And again, Satish and me were taught by Dr. Dharambir Sethi. And there are people who do it without intact bulla also, which are also good techniques. But in my hands, I am comfortable with the intact bulla technique, sir.
Okay, sir.
Yeah. Debrider. See, now I am happy because I can see clearly the roof of my maxillary sinus. Right?
Yes, sir. Medial
Because
avicular
this
floor.
is a very, very important landmark in the entire fest, no matter what revision you are doing. Okay? So this horizontal line, if you stay along with this, you are unlikely to damage the skull base when you are opening the posterior ethmoid or the sphenoid. Right?
Yes, sir.
Yeah. Merosel, please. So I will be finishing this case at about 11 o'clock. Then we have the master, Dr. Vijayendra, one of the seniors who have tremendous admiration and respect. I mean, his work culture, the discipline, the amount of effort he has put in his life and mastered the ear surgery, the facial nerve, as well as the tympanosclerosis is amazing. And I think he's showing one more case of facial nerve today. And he is so humble and unassuming that he calls me a legend. I am anything but a legend. So now let us look into the frontal sinus. I'll keep a couple of mirror cells. Is the picture okay?
Yes, sir.
Yeah.
We're able to see very clearly.
Sponge. What degree forceps? Now I'll take out the sponge in the frontal recess.
Yes, sir.
Right?
Yeah. Yeah, excellent, sir.
Yeah. Ball probe. I think we'll do put a 70-degree scope and palpate further. 70-degree scope and give me the long ball probe. Now, for the first time in the entire surgery, I am moving from 0 degree to 70 degree. If you are a beginner or if you are a moderate, medium level surgeon, it is better you try to do most of the procedure with 0 degree and use 70 degree wherever necessary and possible. Okay?
Yes, sir.
Can you see this?
Yeah.
Long ball probe.
হ্যাঁ তোমার ইয়েটা আলাদা হয়ে যাচ্ছে তাই প্লেন আর অ্যাঙ্গুলেশনটা
Yes. This is the frontal beak. Probably there is something that is moving here. 45-degree forceps. Ball probe, long.
Couldn't see.
Yes,
Couldn't see, sir. Yeah.
that is my frontal sinus there.
Yeah.
I'm just trying to palpate here. Sponge again. What 45-degree forceps? Give me the debrider, please. Let me just. Can you see the movement of the eye here?
Yes, sir.
Can you see the Stankiewicz sign?
Yes, thank you. Yes, sir. Yes.
Yes. So that means I should not move further here.
Yeah.
Okay. If I put a